Imagine, for a moment, a hospital where a smart system could accurately predict a patient's risk of dying before it actually happens. Not with a crystal ball, but with data.
Right.
How profoundly could that foresight change everything? It could mean earlier interventions, maybe more targeted care, and ultimately a significant leap in patient safety and, well, healthcare quality overall.
Absolutely. A huge potential impact.
Today, we're diving deep into precisely that, the critical world of predictive modeling in healthcare. We're focusing specifically on the complex challenge of, accurately predicting hospital mortality.
It's a big one.
Our mission in this deep dive is to explore a pivotal study, one that put a powerful hospital mortality prediction model through really the ultimate test, external validation in a completely new and distinct patient population. We'll uncover why this rigorous validation is so crucial and what its success means for the future of how we assess healthcare quality.
Yeah, what it means going forward.
And all our insights today are rooted in the journal article. The Kaiser Permanente inpatient risk adjustment methodology was valid in an external patient population by Van Walraven, Escobar, Green, and Forster, published back in 2010.
A key paper in the field.
Okay, let's unpack this then. Why is having a robust model, a really good model, to predict hospital mortality so vital for healthcare systems? What's really at stake if we don't have one?
Well, it's truly foundational. Accurately measuring hospital mortality risk is how we establish a reliable baseline.
Right.
Without it, how can we truly assess the quality of care being provided? And maybe even more importantly, it's how we fairly compare the performance of different hospitals, different providers.
Okay.
If you can't accurately predict the expected outcomes based on the patient mix, you're essentially comparing apples and oranges.
Yeah, that makes sense.
And you might miss where real improvements are desperately needed, or conversely, you might unfairly penalize genuinely good care just because they treat sicker patients.
And the study puts a huge emphasis on external validation. What exactly does that phrase mean for a model like this, and why is it absolutely non-negotiable for proving its true worth?
So what's fascinating here is that a predictive model might look absolutely perfect, statistically perfect, in the specific environment where it was initially developed. It could fit that original data like a glove. But external validation, that's the rigorous stress test.
Yeah.
It's the step that proves the model's functionality isn't just some kind of statistical fluke.
Right. Not just specific to that one place.
Exactly. Not unique to those original patients or those specific doctors or the particular data system it was built on. Think of it like a new drug. It might work wonders in a controlled lab setting.
Okay.
But until it's tested in diverse, real-world populations, you don't truly know its broader efficacy or, frankly, its safety profile.
I see.
And this article specifically highlights that the Escobar et al. Model, the focus of this study, was, at the time it was published, the only published model of its kind needing this crucial external test. Yeah, that really underscores how significant this validation effort was.
So the study zeroes in on validating what's called the Kaiser Permanente inpatient risk adjustment methodology. Can you give us a quick overview of this model? What kind of data does it actually leverage?
Certainly. So this methodology was originally developed and then internally validated using data from, get this, nearly 260,000 hospitalizations.
That's a lot of data.
Huge amount. Across 17 different hospitals, all within the Kaiser Permanente health plan. Its core design is to predict hospital mortality using, and this is key, routinely collected patient-level data.
Okay.
Data that's available right at the point of admission. The aim is efficiency. Get these predictions early to potentially inform care decisions.
And what specific patient information are we talking about? What are the key ingredients that feed into these predictions?
The model incorporates 6 key factors, or covariates as they're called. These include the patient's age. And it's quite sophisticated, actually, not just a simple number. It uses techniques like a squared natural spline and interaction terms to capture age's complex, sort of nonlinear relationship with risk. Because risk doesn't always increase steadily with age in a straight line, right?
So it can plateau or accelerate.
Exactly. Then there's patient sex. How urgent their admission was, basically elective or emergent. The service they're admitted to, like medical or surgical, and their specific admission diagnosis.
Okay.
And finally, it uses 2 powerful summary scores. The laboratory-based acute physiology score, or LAPS, which measures the severity of their acute illness based on lab results.
LAPS. Got
and
it.
the comorbidity point score, or COPS, which assesses their burden of chronic underlying health conditions.
HAPS for comorbidities. Okay,
Yes.
so a lot of information, but as you said, all routinely collected, which sounds like a big deal for practical application.
It is. That's crucial for real-world use.
Now, for this external validation, the researchers took the Kaiser Permanente model to a completely different environment. Ottawa, Canada. Tell us about the Ottawa Hospital, TOH, as a setting for this pivotal study.
Right, so the study was conducted at the Ottawa Hospital, TOH. It's a large tertiary care teaching facility. And crucially, it operates within a publicly funded healthcare system.
Ah, so different from the U.S. Kaiser system.
Very different structure compared to Kaiser Permanente's integrated managed care system. The study included a substantial cohort, nearly 189,000 adult inpatient admissions over about 4 years. And they carefully excluded certain patient groups, like kids under 15, OB admissions, and interhospital transfers, just to make sure the population was relevant for testing this specific kind of model.
This next point seems really pivotal. How did the patient population in Ottawa actually compare to the original Kaiser Permanente cohort where the model was developed? Was it like a fair comparison, or was it intentionally designed to be a significant stress test for the model?
Oh, it was absolutely designed to be a significant stress test. The source itself describes it as an extensively different patient population.
Extensively different. Okay.
Honestly, think of it like taking a finely tuned Formula One car, designed for a smooth, perfect racetrack, and asking it to win a rally race on some muddy, icy mountain pass. It's that different.
Wow, okay. Give me some specifics.
Sure. The Ottawa patients were notably younger, age 54 versus 63 in the original KP cohort.
Okay, younger.
They also had a lower average acuity of illness. The median LAPS score was 0 in Ottawa versus 13 at KP.
0 versus 13, big difference.
Huge difference. And significantly fewer documented chronic comorbidities. The median COPS score was 28.5 in Ottawa compared to 74.1 at KP.
So less acutely ill, less chronically ill on paper.
On paper, yes. But perhaps the most critical difference, the real kicker, was that over 80%, 0% of the Ottawa cohort had no laboratory tests recorded within 24 hours of admission.
80% had no labs, but LAPS is based on labs.
Exactly. This is in stark contrast to the original Kaiser Permanente cohort, where 100% had labs informing the LAPS score.
So the model was flying blind for a huge chunk of the population on a key predictor.
Pretty much. It meant the model was essentially trying to predict outcomes with significant blind spots for a key input like LAPS for a large majority of the patients.
So the model was tested on a population where some of its crucial data inputs were either missing entirely for a huge segment or just had very different characteristics compared to its training ground. That sounds like a truly demanding validation for any predictive tool.
Absolutely. A very tough test.
So what happened? What happened when the original Kaiser Permanente model, let's call it Model A, was applied directly to the Ottawa data with its original parameters, the ones learned at KP?
Okay, so Model A, using those original parameter estimates from Kaiser, it actually demonstrated excellent discrimination.
Excellent discrimination.
Yes, it had a C statistic of 0.894. Now, for those less familiar, the C statistic, or concordance statistic, essentially measures how well a model can distinguish between patients who will experience an event, in this case, sadly, death, and those who won't. A value close to 1, like this 0.894, is considered excellent. It tells us the model was still very good at telling us who was generally at higher risk versus lower risk, even in this new population.
So it could rank people correctly, more or less.
Broadly speaking, yes. It could rank the risk pretty well. However, and this raises an important question, while its discrimination was excellent, its calibration was poor.
Calibration, what does that mean here?
Calibration tells us if the predicted probability of an event actually matches the observed rate of that event in the real world. Is the model predicting a 10% risk for a group that actually has a 10% mortality rate?
I see. So how was Model A's calibration?
It was poor. They used the Hosmer-Lemshow test, and the statistic was huge, 4,009, with a tiny p-value, less than 0.000001.
Which means?
Which strongly indicates that the model was systematically off. Specifically, it was consistently underestimating the observed mortality rates across almost all the risk groups in Ottawa.
So it knew who was high risk, but it thought the risk was lower than it actually was.
Precisely. It had the right general idea of the risk order, but its absolute risk predictions were significantly too optimistic for the Ottawa setting.
So while it could pinpoint who is vulnerable, it seems the model was consistently too optimistic about survival in Ottawa. What are the practical dangers, for hospitals and patients of having a prediction tool that, despite its excellent discrimination, consistently underestimates the true risk?
Well, the danger is significant, isn't it? Imagine a hospital using this model thinks its expected mortality rate for a group of patients is just, say, 1% according to the model.
Yeah.
But in reality, the true rate for that group in their hospital is 5%. That's not just some academic error.
No, that sounds serious.
It creates a false sense of security. It could potentially lead to missed opportunities for intervention, maybe misallocation of resources like ICU beds, and tragically, maybe even outcomes that might have been prevented if the model's predictions were truly aligned with reality.
Right. You might not monitor someone closely enough if you think their risk is lower.
Exactly. But this brings us to the crucial turning point of the study, the power of recalibration.
Recalibration, okay.
So, what the researchers did next was brilliant. They used the exact same set of variables, age, sex, LAPS, COPS, etc., but they generated new parameter estimates using the Ottawa data itself.
Ah, so they retrained the model's weights, basically, using the local data.
Essentially, yes. They recalibrated the model for the local population, creating what they called Model B. And the results were dramatically better.
How much better?
Discrimination improved even further, edging up to an excellent statistic of 0.915. But the big win was calibration. It improved greatly.
Okay.
The Hosmer-Limshow statistic dropped way down to 18.0, and the p-value is now 0.02, which is statistically non-significant in this context, suggesting a good fit.
So the predicted rates now match the actual rates much better.
Yes. Now, the expected mortality rates were largely aligned with the observed rates across most risk deciles. The model wasn't systematically underpredicting anymore.
What's fascinating about this finding is that it suggests the core logic, the underlying structure of the Kaiser Permanente model, is incredibly robust. It wasn't fundamentally broken.
Exactly.
It just needed a local tune-up, basically, to learn the specific statistical patterns and baseline risks of a new environment through this recalibration.
Precisely. The engine was sound. It just needed tuning for the local conditions. And furthermore, the study investigated if other widely accepted comorbidity indexes could be substituted for COPS.
Why would they do that?
Well, COPS sometimes requires proprietary software to calculate, which might be a barrier for some hospitals.
Ah, okay. Practical reasons.
Right, so they tested replacing COPS with either the Elixir index or the Charlson index. These are very common, publicly available comorbidity measures creating models C and D, respectively.
And how did those perform?
They still maintained excellent discrimination and calibration. For example, the Elixir model, Model C, had a C statistic of 0.901, and the Charlson model, Model D, was 0.894, both very strong.
Wow.
So this shows the underlying method, the KP methodology itself, is quite flexible.
That flexibility sounds incredibly promising. The methodology isn't rigid. It can adapt to different ways of measuring chronic illness burden and still remain accurate and well-calibrated after that local adjustment.
Huge practical advantage.
But does this flexibility introduce its own set of challenges? I mean, if different hospitals are using different comorbidity indexes, does that complicate comparisons between them, even if the model performs well internally at each place?
That's a really perceptive question. And yes, it's a trade-off. You're right. While it boosts accessibility for individual institutions, which is great, it can indeed complicate direct apples-to-apples comparisons between hospitals if they're using different comorbidity measures within the same framework.
Right.
The key would be consistent application within a reporting system, or perhaps agreeing on a standard measure if the goal is broad benchmarking. But often, the benefit of allowing more hospitals to use a powerful, locally calibrated tool outweighs that specific comparability challenge.
Okay, that makes sense. So after this deep dive into the findings, what does this all mean for you, the listener, for patient care, for healthcare systems generally? What's the big so what here?
Well, if we connect this to the bigger picture, this study provides really robust evidence that the Kaiser Permanente inpatient risk adjustment methodology is a valid and, crucially, highly adaptable tool for predicting hospital mortality risk.
Valid and adaptable.
Yes. It performs exceptionally well, even in very diverse patient populations. And even when you swap out components like the comorbidity measure, provided, and this is the important caveat, it's appropriately calibrated to the local data.
Right, that recalibration step is key.
It's absolutely key. This is a significant affirmation of its broad utility and its potential to become perhaps a standard tool across many different kinds of healthcare systems.
The study also highlights the need for detailed patient-level data for these models to work effectively. Is this mostly a barrier, do you think, or is it also an opportunity for improvement in healthcare systems?
It's kind of both, actually. On one hand, it definitely underscores the importance of having access to rich, granular patient data. Better data generally leads to better models. That's a clear opportunity for systems to improve their data infrastructure. However, the model's success in Ottawa, despite what the paper calls the undercapture of acute and chronic disease burden, largely due to fewer outpatient data points or those missing admission labs we talked about,
Yeah, that was surprising.
that success is actually a powerful finding in itself. It suggests that cross-institutional collaborations for validation and implementation are feasible. You don't necessarily need the exact same depth of outpatient data sources everywhere if they're just not available.
So local recalibration can kind of bridge those gaps.
It seems it can, effectively. It compensates for those differences in data characteristics.
And the finding about being able to use the Elix-Hauser or Charlson scores instead of COPS, you mentioned practicality, but that seems like a major win for accessibility too.
Oh, absolutely. That's a crucial practical takeaway.
Yeah.
It means institutions that might not have access to specialized software or the specific data needed for COPS can still potentially implement this powerful risk adjustment methodology using tools they already have or can easily get.
Right.
This significantly increases its accessibility across different healthcare systems, making advanced risk prediction more attainable for a wider range of hospitals. And that's a huge step forward for potentially standardizing how we look at quality assessment.
Looking ahead then, are there any significant challenges or maybe prerequisites for broader adoption of this methodology beyond its current scope? What hurdles remain?
Yes, the study does identify several. First, as we touched on, it requires access to digitized, patient-level diagnostic data, lab results, demographics, hospital information, all linked together.
Which isn't universal yet.
No, some facilities may lack this integrated data infrastructure or maybe the expertise to link and analyze it easily. That's a barrier.
Yes. What else?
Second, the methodology, at least in the form validated here, requires an admission diagnosis code. And that's not a universally required data element in all healthcare systems. The paper mentions, for example, Canadian hospitals or some European systems might not routinely assign one right at admission.
Ah, so a data standard issue.
Potentially, yes. And finally, work would be required to translate and validate the model for data coded using ICD-10, the newer diagnostic coding system, as opposed to the ICD-9-CM system that was used in the original model development and this validation study.
Right, keeping up with coding changes. Could this model be made even better, do you think? Or is it sort of already at its peak performance given the data it uses?
Oh, absolutely. There's always potential for further enhancement.
Yeah.
The researchers themselves point this out.
What do they suggest?
They suggest that the current model doesn't incorporate some potentially important information that is often available. Things like the patient's presenting vital signs, heart rate, blood pressure right at the start, or the patient's immediate response to emergent therapy, if they received any. Their baseline functional status, how independent were they before getting sick?
Yeah, that seems important.
Or even how they arrived at the hospital. Did they walk in or come by ambulance? Integrating such routinely collected data, if it's available and consistently captured, could potentially refine the model's discrimination and calibration even further, make it even more accurate.
Interesting. Now, this raises an important question. We've focused a lot on hospital mortality. It's undeniably a critical outcome, a powerful indicator. But is it the only measure we should be using for assessing hospital quality, or even the best one in all cases?
That's a great point, and no, not exclusively. The study authors wisely point out that while mortality is essential, it might not actually be the optimal measure for monitoring the quality of care for many specific diseases.
Why not?
Well, think about it. Patients might, for instance, survive the hospitalization but then die shortly after discharge. That death wouldn't be captured in hospital mortality stats. Or patients might survive but suffer other poor outcomes, like increased disability, a significant decline in their quality of life, or needing long-term care. These outcomes could actually be more sensitive indicators of differences in the quality of patient care provided during the hospital stay.
So we need a broader view.
Exactly. A truly comprehensive assessment of hospital quality requires looking at additional outcome measures beyond just in-hospital death to provide a more complete picture of patient well-being and recovery.
Okay. So, wrapping up, we've explored how a robust methodology for predicting hospital mortality underwent truly rigorous external validation. It proved its adaptability and its utility even in vastly different healthcare environments.
Hmm.
It's really a powerful reminder, isn't it, that truly effective tools require that hard-nosed testing and often that local customization, that recalibration to reach their full potential.
Well said. That local tuning is vital.
Now, for a provocative thought to leave you with, imagine a future where such validated and recalibrated predictive models are not just used for mortality, but for a whole array of patient outcomes.
Yeah, beyond just survival.
Right. Think about predicting readmission risk, or the likelihood of a patient making a full recovery, or their risk of disability after discharge, or even their chances of going home successfully versus needing facility care.
A much richer picture.
How could this kind of data-driven foresight fundamentally reshape healthcare? Could it make it not just reactive, but truly proactive, more personalized, and deeply focused on patient well-being at every single stage of their journey?
It's a compelling vision for the future.
We encourage you, our listeners, to consider how ongoing advancements in data science, machine learning, and collaborative research might continue to refine these essential tools, really pushing the boundaries of what's possible in preventative care and quality assessment.
Lots more to come in this space.
Until next time, keep diving deep.